Hello and welcome to the Point of Care podcast. Today's episode is on the inpatient management of acute pancreatitis. For some background in epidemiology, pancreatitis is responsible for 30,000 emergency room visits in the U.S. annually and is the most common GI cause of hospitalizations in the U.S. Inflammation of the pancreas leads to hypersecretion and/or backflow of digestive enzymes into the pancreatic tissue, leading to autodigestion and capillary leak, which leads to local and systemic edema and third spacing, and in severe cases, a shock-like state. Acute pancreatitis is caused by an acute trigger leading to inflammation and is reversible. 20% of patients will develop moderately severe or severe pancreatitis, which is characterized by organ failure and systemic complications. Mortality is low in patients without evidence of organ failure, but as high as 30 to 50% in those with severe pancreatitis due to multi-organ dysfunction and risk of sepsis from an infective pancreatic necrosis. A note on chronic pancreatitis, which is a distinct disease process, chronic pancreatitis will eventually lead to irreversible damage to pancreatic functioning, and it's mostly associated with chronic alcohol use. Chronic pancreatitis does not present with pancreatic dysfunction until a vast majority of the pancreatic tissue is damaged. Exocrine pancreatic dysfunction can present as malabsorption, such as steatorrhea or weight loss. Endocrine pancreatic dysfunction can present as diabetes with polyuria and polydipsia. For your admission checklist, for the ABCs, assess for hypotension and shock, and respiratory distress that might be concerning for pleural effusions or ARDS. To diagnose pancreatitis, you need 2 of 3 of the following: a consistent clinical presentation, a lipase over 3 times the upper limit of normal, and imaging consistent with pancreatitis. Usually, you can diagnose pancreatitis with the first 2. To triage patients, you can use the BISAP score on admission, which includes BUN, altered mental status, SIRS criteria, age over 60, and the presence of pleural effusions. If you have more than 2 of those, it's considered to be severe pancreatitis. Note, however, that some of these risk stratifying scores are not perfect, and we'll talk about that later. A better way to triage is to think about organ dysfunction and systemic complications. It's considered mild pancreatitis if there's no organ dysfunction or systemic complications, moderate pancreatitis if there's evidence of organ dysfunction that resolves within 48 hours, or severe pancreatitis if the organ dysfunction persists for more than 48 hours. When doing your chart check, look for a history of alcohol use and their risk of withdrawal, any prior episodes of pancreatitis and complications they've had, a history of gallstones, hypertriglyceridemia, hypercalcemia, and any recent ERCPs. You can't miss sepsis or shock, an acute abdomen, cholangitis, ARDS, necrotizing pancreatitis, or hemorrhage. For your admission orders, make sure there's a lipase, LFTs, a pregnancy test in all females of childbearing age, a lactate if you're concerned about shock, a right upper quadrant ultrasound in all comers, a chest x-ray, strict I's and O's, decide on the patient's diet, and consider if there's a need for a CT abdomen pelvis if the diagnosis is not clear. Once you know you're treating pancreatitis, the initial treatment to consider includes starting fluid resuscitation with a 10 mg per kilogram bolus, followed by 1.5 cc's per kilogram per hour. Replete the patient's lights and treat their pain and nausea. Start with NSAIDs and opioids. When you see the patient, for your HPI intake, ask them about their pain, the onset, duration, character, severity, location, radiation, and exacerbating or relieving factors. Also ask about any associated symptoms, including nausea and vomiting, fevers, malabsorption, such as steatorrhea and diarrhea, dyspnea, and weight loss. Ask about the preceding history, including alcohol use, fatty food ingestion, a procedure such as an ERCP, trauma to the abdomen, infectious symptoms, or any new medications. Comorbidities you should ask about include a history of gallstones, alcohol use disorder, hypertriglyceridemia, hypercalcemia, sclerosis cholangitis, and retroperitoneal fibrosis. When performing your physical exam, look at their general status and vitals. Are they in distress, fevering, have tachycardia or hypertension, and what's their respiratory rate? For your pulmonary exam, note any dull breath sounds that might be consistent with an effusion. For your abdominal exam, see whether they're tender to palpation, if they're guarding, have distension, or any palpable masses. The Cullen sign, which is periumbilical ecchymosis, or the Gray-Turner sign, which is flank ecchymosis, can suggest severe pancreatitis. Also note any reduced bowel sounds that may suggest an ileus. For the extremities, note the presence of any lower extremity edema, the skin turgor, and evidence of a DVT. And for their skin exam, note whether they have jaundice. For the etiology and differential, common causes of acute pancreatitis include gallstones, alcohol, and idiopathic causes. Less common causes include hypertriglyceridemia, autoimmune pancreatitis, hypercalcemia, drug-induced, trauma, infections such as Coxsackie B and mumps, and toxins and venoms such as the classic scorpion sting. Some common drugs that can cause pancreatitis include loop and thiazide diuretics, ACE inhibitors, azathioprine, sulfa drugs, metronidazole, valproic acid, statins, fibrates, protease inhibitors, and estrogens. And it's very important to be considering other common causes of epigastric pain, which can include acute peritonitis and MI, peptic ulcer disease, choledocholithiasis, cholecystitis or cholangitis, biliary colic, an SBO, mesenteric ischemia, and an aortic dissection. For the plan for your workup, make sure you have a CBC to look for leukocytosis and hemoconcentration, a BMP to look for calcium, a MAG and FOS to assess for any downstream effects of alcohol use disorder, LFTs to assess for gallstones or cholangitis, coags, lipase of course, lactate to look for shock, a pregnancy test, and send a lipid panel if you're concerned that this is a new diagnosis. You can also send an IgG4 level if you're concerned for autoimmune pancreatitis in the right clinical context. You can get a chest x-ray if the patient's dyspneic or you're concerned about ARDS or effusions. A right upper quadrant ultrasound can be ordered in most patients to rule out gallstones if you're not concerned about alcohol. A CT abdomen pelvis with contrast can be ordered if the pain is truly severe, if you're not sure about the diagnosis, or it's not improving after 48 to 72 hours and the symptoms are continuing to get worse, such as ongoing fevers, worsening pain, or changes in the patient's vital signs. ERCPs tend to be reserved for gallstone disease or cholangitis. Ideally, if there's stones present, you'll get a cholecystectomy prior to the discharge. For your treatment, when it comes to fluids, start with a 10 milliliter per kilogram bolus of LR followed by 1.5 cc's per kilogram per hour in the first 24 hours. For pain, you can give ketorolac 15 to 30 milligrams Q6 PRN, oxycodone PRN with hydromorphone as a breakthrough. In general, trial PO but give IV if you need bowel rest or if the patient's just not tolerating anything by mouth. You can prioritize NSAIDs with opioids as breakthroughs, and only do a PCA if you think it's really needed. For nausea, be thinking about ondansetron 4 to 8 milligrams Q8 PRN, dissolving or IV, or Reglan. For diet, the best thing to do is have early PO intake within 24 hours. You can start the patient on a clear liquid or a soft diet and advance as tolerated. You should start tube feeds if there's no PO intake at the 5 to 7 day mark. Alcohol-related pancreatitis should also be treated with prophylactic thiamine or B1 and pyridoxine B6, and such patients should receive counseling on AUD. Antibiotics are reserved for patients with infected necrosis or who have evidence of a different type of infection. Hypertriglyceridemia is treated with an insulin drip, 0.1 to 0.3 units per kilogram per hour acutely, and then fenofibrate for the long term. You can consult surgery or interventional radiology colleagues to discuss drainage or necrosectomy and debridement in patients with evidence of local pancreatic complications. If you remember nothing else, make the diagnosis with 2 of 3 of the following: a consistent clinical picture, a lipase greater than 3 times the upper limit of normal, and imaging findings associated with pancreatitis. Give fluids, but not too much, typically starting with a 10 ml per kilogram bolus of lactated ringers, followed by a maintenance rate of 1.5 cc's per kilogram per hour for 24 hours. Analgesia should start with NSAIDs and opioids as needed. Shoot for early PO intake as tolerated, even in severe pancreatitis. If the pancreatitis is new and not obviously related to alcohol, get a right upper quadrant ultrasound and triglyceride level to search for an etiology. Regularly reassess for complications such as organ failure and infected necrosis, and adjust management accordingly to involve consulting services such as IR and surgery. For some pearls related to the pathophysiology of pancreatitis, the pain is associated with inflammation, swelling, and stretching of the pancreatic capsule. Peripancreatic fluid is thought to be the result of rupture or leaking of fluid from the pancreatic ducts, and this fluid is sterile and will likely resolve spontaneously. If it doesn't, it may turn into a pseudocyst with a defined wall. Hypercalcemia can lead to pancreatitis via premature activation of digestive enzymes within the pancreas, direct pancreatic cellular damage, and calcium salt deposition in the pancreatic ducts, leading to reduced flow. Pancreatitis itself can lead to hypocalcemia because lipase breaks down fat into fatty acids that in turn bind to calcium in circulation, leading to saponification, which is white chalky deposits. Hypertriglyceridemia can lead to pancreatitis via the development of toxic metabolites from elevated free fatty acids, increased blood viscosity, and endothelial damage, leading to ischemia and increased capillary leak. For some pearls related to the etiology and risk factors, in general, most scoring systems for acute pancreatitis are too cumbersome to calculate and only identify severe disease as it develops, limiting their clinical utility and ability to intervene using the information. Moreover, they tend to perform poorly at predicting the actual severe disease. BISAP, or the Bedside Index of Severity of Acute Pancreatitis score, is used to predict in-hospital mortality and can be done on presentation. If it's 0 to 2, the mortality is less than 2%, and if it's 3 to 5, mortality is greater than 15%. The modified Marshall score can be used to assess for organ dysfunction. The Ranson score was historically used to estimate the severity of pancreatitis and associated prognosis. However, its use is limited by the inclusion of uncommonly collected labs and the need to repeat an assessment after 48 hours. A hematocrit over 44 and a BUN over 20 are independent predictors of severe pancreatitis and mortality, respectively. This is likely because it implies hemoconcentration and that there's already early fluid sequestration in the pancreas. Pancreatitis can happen after ERCPs in about 5 to 10% of cases. This can be due to trauma during ductal manipulation, potential disruption of the sphincter of Oddi, and increased pressures or direct chemical injury from contrast injection. Meta-analyses have shown that rectal NSAIDs can help to prevent the development of acute pancreatitis after an ERCP. For some pearls related to presentation and diagnosis, the classic pain associated with pancreatitis involves radiation to the back because the pancreas is a retroperitoneal organ, worsening with meals due to the release of digestive enzymes, increased blood flow, and inflammation to the pancreatic area, and the pain is worse when lying supine and relieved when leaning forward due to increased and decreased pressure on the pancreas. Patients will often present with fever, leukocytosis, and other SIRS criteria without any underlying infection, so be judicious with antibiotics. Cullen and Gray-Turner signs are caused by localized hemorrhage within the pancreas, diffusion of blood along the peritoneal planes, and gravity causing migration to the periumbilical and retroperitoneal areas. Their presence should imply severe pancreatitis and usually don't present for several days. Lipase is 90% sensitive and specific for pancreatitis, and there's not much of a role for amylase anymore. The negative likelihood ratio of lipase is not The negative likelihood ratio, if lipase is not increased, is negative 0.01. In other words, if lipase is not elevated, it's almost certainly not acute pancreatitis. The level of lipase elevation does not correlate with either the severity of pancreatitis or the risk of developing complications. Lipase elevation happens within 6 hours in acute pancreatitis and can be elevated for weeks. There is no value in rechecking the level to trend disease progression. Lipase may be normal in chronic pancreatitis. Lipase may also be elevated in renal failure, cholecystitis, and appendicitis due to local inflammation that then affects the pancreas, as well as gastroenteritis. An elevated ALT greater than 150 has a 95% positive predictive value for biliary pancreatitis. Amylase can also be elevated in pancreatitis. A CRP greater than 150 can indicate severe pancreatitis, and some guidelines recommend checking daily for the first 3 days. An elevated level on day 3 is an independent prognostic factor. Triglycerides may be falsely low in patients presenting with pancreatitis due to a fasting state. CT findings of pancreatitis include enlarged pancreatic parenchyma with edema and fat stranding, and peripancreatic edema. Findings in chronic pancreatitis may also include pancreatic calcifications. A right upper quadrant ultrasound is valuable for diagnosing gallstone disease by directly visualizing cholelithias or indirectly seeing dilated biliary tree. But the sensitivity for acute pancreatitis is low, often due to poor visibility from the presence of bile gas. For some pearls related to treatment, severe pancreatitis is treated like septic shock with resuscitation. Historically, patients receive 200 to 300 cc's per hour for the first 24 hours, resulting in a positive fluid balance of 5 or more liters on the first day of admission in order to protect end organ perfusion. Recent data from the Waterfall trial suggests that a more conservative fluid administration plan is just as efficacious, but leads to fewer complications, including volume overload and pulmonary edema. PCAs can be considered for pain management. However, their utilization may lead to worse outcomes, including increased length of stay and time to enteral nutrition. Patients overall will benefit from early enteral nutrition. Historically, there was concern that feeding patients would stimulate the pancreas to dump all of the digestive enzymes and lead to liquefactive necrosis, and thus parenteral nutrition was preferred. However, this is largely a myth. Enteral nutrition is associated with decreased mortality, organ failure, systemic infections, and the need for surgery. And the proposed reason for this is that enteral feeds prevent gastrointestinal dysmotility, permeability, and thus edema and bacterial translocation. ERCP in pancreatitis is not urgent unless the patient has evidence of concomitant cholangitis, in which case it should be done within 24 hours. Patients with hypertriglyceridemia over 1,000 are treated with insulin in the acute setting with the goal to get the level less than 500. Insulin decreases lipolysis, which inhibits hormone-sensitive lipase, enhances triglyceride clearance via activation of lipoprotein lipase, and reduces hepatic triglyceride production. Patients may need to be given dextrose as well. Patients with autoimmune pancreatitis are treated with steroids, and repeat episodes may need to be treated with immunosuppressive agents. Patients with gallstone pancreatitis should have a cholecystectomy done once they've recovered. The recurrence without surgery is 25 to 30%. For some pearls related to complications, the complications are often not seen on imaging until a few days after the start of pancreatitis. Necrotizing pancreatitis, abscess, which is now referred to as walled-off necrosis, given the fluid collections are actually mostly sterile, pseudocyst, and pancreatic hemorrhage are all complications to be aware of. Peripancreatic fluid collections turn into pancreatic pseudocysts, and acute necrotic collections become walled-off necrosis if either persists and they develop a defined wall. 30% of patients with pancreatic necrosis will develop an infection. It will most commonly happen after 10 days of pancreatitis symptoms. Procalcitonin may be useful for ruling out infected pancreatic necrosis. If the level's low, it's very unlikely the patient has an infection, according to 2019 guidelines. In infected necrosis, imaging may show gas on the CT. Infected pancreatic necrosis is treated with cefepime and metronidazole or a carbapenem monotherapy for at least 4 weeks, adjusting based on aspiration cultures. Pancreatic pseudocysts may need drainage or excision given only 40% resolve spontaneously. However, necrotic collections are frequently misdiagnosed as pseudocysts because distinguishing between solid and liquid content on CT is challenging, and necrotic collections cannot actually be drained. Aggressive fluid administration in the setting of acute pancreatitis, which is a state with a proclivity for third spacing fluid, can lead to abdominal compartment syndrome. Look out for distension, pain out of proportion to exam, and oliguria, which can indicate renal compromise. The duodenal and splenic blood vessels are the most commonly affected arteries in pancreatitis and can be eroded by severe inflammation, which leads to hemorrhage. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.